Right, very good evening, and coming to the penultimate session of our advanced flow cytometry course. Today we'll discuss on myeloma MRD. Okay, so the plan for today is quickly discuss myeloma MRD. We can just cover a bit of sensitivity. So, what is this sensitivity in eye event acquisition, especially in MRDs? What is limit of blank, what is limit of detection, what is limit of lower limit of quantification, and all those things I can give you an idea today. So that's the plan, and we can just quickly see some two MRD cases of myeloma live analysis, because I want to reserve tomorrow for MDS. Okay, so tomorrow we can just go through MDS and see some one or two cases of MDS, how flow could be useful. So that's the plan. So today I want to finish off myeloma MRT discussion along with establishing the sensitivity of an MRD assay with experiments like LOB, LOD, LOQ, and live analysis of two myeloma cases. That's the plan for today. And tomorrow we'll deal with MDS. So when I asked for opinions, there were some opinions related to AML MRD. Now see, if I want to take AML MRD, okay, it is not that easy. First of all, it is more complicated than PMRD, TMRD, myeloma MRDs. It is a bit complicated. Second is that if I'm going to open up that, like it is like a Pandora's box, I'm very sure you will not definitely understand. And in fact, opening it up will raise a lot of confusions. And third is like, for me to take a session on that, I need to be a super expert. Okay, whenever I want to discuss something, or if when I want to teach something, I should be an expert in what I'm talking. I should know, I should be confident of what I'm talking. But myeloma MRD, I feel I'm not yet there. Okay, I'm doing it, but still to guide others, I may need some more experience, because a lot of light has been coming on AML MRD recently. So for me to guide you all and teach you AML MRD, I don't find that this is the right point of time. And in fact, it is not easy to teach also with because it's a bit complicated. So once I'm there and I feel that I can able to teach someone, then I'll take it up. And at that time I'll inform and we can have a session on that. But currently, if I'm going to take AML MRD, it may not be clear to you, and it is something like it is very difficult. And instead of giving clarity at the end of the course, it would end up in a confusion. So I don't want to do that. So people who are doing currently DMRD, TMRD, and myeloma MRD, then AML MRD is something needed, which I'll teach you sometime later. But those who have not started MRD, please start with these three things. That would be better. Okay. Am I audible?
Yes, sir.
Yes, sir.
Perfect.
Yes, sir.
So that is the reason why I don't want to take AML MRD into the current course. But we'll definitely do it in future. Okay. Right. The one problem with AML MRD is that, see, for BMRD, it is like your the disease is differentiating towards B cells. Okay. For TMRD, it's much more easier because it's differentiating to T cells, and even that is not happening in the marrow. So it is very easy. Myeloma, again, you know what you are targeting for. But AML MRD, it's an heterogeneous disease where the stem cells are differentiating to so many lineages. So you need to know all these things, all these maturation patterns, or multiple maturation patterns, in fact, so to be a master of detecting residual disease in AML. So I don't want to open it now. It is not possible to cover or give a glimpse of it even in a session. It needs multiple sessions. So I don't want to touch that now. Okay, we'll do it sometime later. When I feel I am confident enough to teach people, I'll take it up. Okay, right. With that, we'll just start with myeloma MRD. So now, the same question what I asked some time back. During a myeloma diagnosis discussion, I said, like, is flow really needed for diagnosis of myeloma? Okay. the same question I just want to ask you now. Like, does MRD have a role in myeloma? Okay. What I personally feel is that flow cytometry at the diagnostic point of view, for in an established case of myeloma where you have 30-40% of plasma cells in the marrow, you have an M band, you have raised serum free light chains, and the patient is having lytic lesions, elevated calcium, high creatinine. In such a case, the diagnosis is almost established, and doing flow does not add much information to it. Okay. So, at diagnostic point of view, given that setting, it may not be that useful. Of course, at diagnostic point of view, when you want to differentiate between a reactive plasma cells and neoplastic plasma cells, better to do flow cytometry. Similarly, when you are want to check whether it's a case of plasma cells of LPL or Waldenstrom's, flow cytometry is very useful. And similarly, it's a case of MGUS. Okay, that also flow is very helpful. But full-blown myeloma, I don't think so. How much flow can help, because it is not going to add additional information. Whereas in MRD, flow is useful. Flow has an advantage. I'll tell you what. Now, these are the investigations we do in plasma cell dyscrasias at the diagnostic point of view. Okay, we do serology where we measure the isotype of immunoglobulin. Okay, and we also measure the light chains. Okay, and the ratio. Similarly, we do electrophoresis for the MBAT. We also see the morphology for the presence of plasma cells. Okay, flow cytometry, cytogenetics, and molecular diagnostics. So these all we do at a diagnostic point, time point. But during when you start treatment and the number of plasma cells decreases and you want to monitor the disease, okay, not all these particular investigations will help you. Definitely morphology will not be of any use, right? So it does not mean like if in morphology you have not seen the plasma cells, so the myeloma is under complete response. No, it can't be. The plasma cells may be in so low in number that you did not encounter that plasma cell when you're doing a differential for 200 cells. Similarly, as the neoplastic plasma cell numbers have markedly gone down, it may not, the immunoglobulin secreted by those low number of plasma cells may not create a M spike. So even this is not useful. So protein electrophoresis morphology may not be useful for monitoring the disease. Similarly, cytogenetics, of course, it is you will be seeing 100 cells for the rearrangements or the signals, and the plasma cells, neoplastic plasma cells have gone so low in number that you may not encounter that during your fish or doing a karyotyping. So even this may not be useful. Molecular diagnostics, yes, it is useful, but you should know what is the rearrangement which was present. See, when you want to do molecular MRD, one important thing what you want to know is what was the molecular signature at the baseline or at the diagnostic point of view. For BMRD, TMRD, and myeloma MRD, you need to know what was the immunoglobulin rearrangement in case of BMRD and myeloma MRD, and what is the TCR rearrangement in case of a TALL or T cell MRD. Okay. Similarly, if it is showing any recurrent abnormality like BCR-ABL positive BALL, then that can be done by PCR. So you always need an initial diagnostic signature to track the MRD when it comes to molecular diagnostics. Okay, so yes, molecular diagnostics can be used for detecting the residual disease or monitoring the myeloma during the course of treatment. Whereas, as I said, protein electrophoresis, morphology, cytogenetics will not be useful. Serology, yeah, to up to one level, you can use serum-free light chains to monitor the disease. Okay, and of course, flow cytometry is definitely useful, and today we'll see how it is helpful in detecting MRD in cases of plasma cell myeloma. Okay, of course, what I've not shown you is imaging. Imaging is one more thing which will be useful to monitor, is the disease progressing or is the disease under control. Okay, but every parameter has its own limitation or analyzing the depth of minimal disease which is present. Now, this is very, very important. Okay, so this is International Myeloma Working Group response criteria. So initially, if you see, like this was a recent response criteria which has been established by International Myeloma Working Group. They said like the response is assessed by progressive disease. That is, it is not, the disease is not responding to your treatment as desired, or on the other hand, it is progressing. So it is becoming more worse. Stable disease is something like it is not coming down and it is refractory to your treatment and it is persisting in the same way as it was during the diagnosis. Okay. Minimal response is like when you have a slight reduction in serum M protein. Okay. And but so it is not, it is response, but not to the level which is desired. So minimal response is like you have greater than 25% or but less than 49% reduction of serum M protein. Okay, or reduction in 24-hour urine M protein by 50 to 89%. Okay, so then partial response is called PR, where you have greater than 50% reduction in serum M protein. Okay, but still electrophoresis is able to pick up that M protein in all these categories. Okay, and 24-hour urine M protein by 90 greater than 90% or less than 200 milligram per 24 hours of for 24 hours. So very good partial response is where your M protein gets disappeared or where there is a greater than 90% reduction in serum M protein. Now electrophoresis is not that helpful. Now what happens is that the next level of detecting the disease, that is free light chains or by immunofixation. Okay. So for assessing very good partial response, you need to detect this M protein not by conventional electrophoresis, but by immunofixation. Okay. I suppose you know what is immunofixation. So it is like you run the sample in gel, which has been already impregnated with different immunoglobulins. Say, for example, anti-immunoglobulin A, anti-immunoglobulin IgM, and something like that. So the immunoglobulin which is secreted by the neoplastic plasma cells will form a band at that respective area. Okay. So until partial response, the serum electrophoresis will be helpful. For assessing very good partial response, electrophoresis may not pick up the MBAT, and now immunofixation will come into play. Okay, which can show you the presence of MBAT. Okay, or the presence of clonal immunoglobulin. So when the patient is nearing to complete response, so then even your immunofixation will become negative. And obviously when immunofixation is negative, electrophoresis will be negative. Okay. And you have less than 5% plasma cell in the bone marrow aspect. Okay. So this is complete response, what they call it as CR. Now going one step ahead, that is, so as I'm going here, I'm going deep into the residual disease. So stringent complete response is something where even your free light chain ratio is normal. Okay, so to put about the sensitivity of the assays, what we are doing first is electrophoresis, where it can pick up the M band. So, but in cases where the patients have attained very good partial response, the M band may not be visible in electrophoresis, and they may show a disease by immunofixation, where they can show that immunoglobulin which is being secreted as well as the light chain which is being secreted. Okay, so when the patient is going for complete response, even immunofixation will be negative, but serum free light chain will be elevated. That is, the light chain which is secreted by the neoplastic plasma cells will be increased and the ratio will be altered. That is, a kappa bar lambda ratio will be altered. In stringent complete response, so even your electrophoresis will be negative, immunofixation will be negative, serum free light chains will also be negative, and there is absence of clonal cells in bone marrow biopsy. Okay, so this is by remember this is by IHC, not by flow cytometry. Okay, so by immunohistochemistry. Okay, so this is about stringent complete response. So this was the one which was present till the last publication, which was released by International Myeloma Working Group. Okay, but now seeing the advancement in flow cytometry and also the need for detecting residual disease much deeper than what was defined earlier, that is stringent complete response, they have included MRD into the response criteria. Now, once a patient has attained a stringent complete response in multiple myeloma, now he is eligible to check for residual disease by one of these techniques. Okay, one is sustained MRD negativity or flow MRD negative, sequencing based MRD negative, or imaging positive MRD negative. So again, you need to do an MRD by one of these two sensitive techniques. One is flow or by sequencing. And then after doing that, you need to put the patient, once if he has attained stringent complete response, you need to insert the patient in any one of these areas. Okay, so this is how now myeloma is coming up. So definitely myeloma MRD is something which is earlier not given much importance, but myeloma MRD is now coming up and it is into a lot of trials, and even it is being used in many European countries to check the response of the disease, and soon it will be coming into standard of care. Okay, so this is the importance of doing MRD assessment in myeloma. Okay, any doubts? Any doubts? You understood, right? So these things you need to, these terms you need to understand. Okay, what is progressive disease, stable disease, minimal response? What is partial response? What is very good partial response? How do they define it? What is complete response? Very good partial response. So in my subsequent slides, I may put the word like VGPR. Okay, VGPR means very good partial response. CR means complete response. SCR means stringent complete response. So all these things you need to know. Okay, till now, any doubts with respect to this IMWG response criteria? No doubts. Great. So why is, how important is attaining an MRD negativity in myeloma cases? You know, myeloma cannot be cured. Okay, it is nothing like myeloma patient is completely cured. That is not possible. There will be some amount of myeloma cells always there. Okay, so what is the importance of getting an MRD negativity in myeloma cases is that, see, MRD status as prognostic value and has been incorporated as an endpoint in majority of ongoing trials. So as I said, this VGPR, then complete response, then stringent complete response was earlier used as the endpoint, but now they felt like even patients who are stringent complete response has a chance of getting a disease relapse. Okay, and also the overall outcome is not that great. So they felt like one more level of response criteria has to be established that should be deep than stringent complete response. Hence, MRD was included into the International Myeloma Working Group recommendation. Okay, so that is what. So it has been incorporated as an endpoint. So now the modified endpoint to know that whether the disease is under control or is MRD is by myeloma MRD. Okay, MRD negativity with the sensitivity of preferably 10 to the power of -6. So this I'll be talking much detail in the subsequent slides. Okay, what is sensitivity? All I'll tell you. So sensitivity of preferably 10 to the power of -6. What do you mean by that? Sensitivity of 10 to the power of -6. Anyone? When I say MRD negativity with the sensitivity of preferably 10 to the power of -6, what does that really mean?
1 in 1 million.
Yeah, so detecting one plasma or one myeloma cell in 1 million normal cells or nuclei. Okay, so that is the sensitivity. When I say 10 to the power of -6, it means detecting one abnormal cell in 1 million normal cells. Okay, so when I say MRD negative with the sensitivity of 10 to the power of -6, it is strongly associated with longer disease-free survival, progression-free survival, and overall survival in patients with multiple myeloma. Okay, the benefit of MRD negativity was seen irrespective of treatment. Okay, so you remember this. For this one, I already said you. Say, for example, a myeloma case who has been classified as intermediate risk or a high risk based on the cytogenetic findings, or that based on the treatment given with anything or any other condition. MRD acts as an independent predictor of the disease. So whatever may be the cytogenetic results or whatever may be the treatment given, when the patient is MRD negative, okay, he tends to have a better overall survival, okay, and better disease relapse-free survival. Okay. Now, meta-analysis is an analysis. So it is demonstrated that progressive-free survival and overall survival benefit increased with higher sensitivity level. This is very important. Say, for example, now I claim myself that I'm doing a myeloma MRD. Okay. And someone asked me how many events do I acquire. So this I'll be talking, but still just giving a glimpse of it. I say like I'm analyzing 1 million events, or I say like I'm analyzing 1 million events. That is not that depth of MRD that has to be seen in myeloma. Okay. When I'm acquiring only 1 million events, I may not be able to hit a sensitivity of 10 to the power of minus 6. So when you say I'm doing a myeloma MRD, you should do it to a sensitivity touching around 10 to the power of minus 6. Okay, if you are not touching this and you are doing an MRD, that MRD may not truly reflect on the results. Okay, for example, when you're acquiring 1 million events, your sensitivity is around, say, for example, 10 to the power of minus 4, and you call that for a case you give it as MRD negative by flow. That patient may still relapse. Okay, when you can't claim like he's MRD negative, he shouldn't have relapsed. The problem is that you have not done a high sensitivity myeloma MRD. You have done a conventional MRD, which may not be helpful, and the disease may relapse because you have not detected that residual disease which was there. Okay, which would have been detected when you have done a next generation flow cytometry or a much sensitive flow cytometry by acquiring a higher number of events. Okay, the benefit of MRD negativity was also significant in patients with relapsed refractory disease. Okay, so even if it's a relapsed myeloma or a refractory myeloma, if they are MRD negative, they had a better outcome. Okay, so these are some of the important indications of or the importance of attaining a negative MRD negative in context of myeloma. Okay, now see, that is what I was saying. So there are two types of doing MRD in myelomas. One is your conventional flow, and other is next generation flow. What I mean by saying next generation flow is obviously the sensitivity, the number of events you are acquiring. Okay, next generation flow is something like you need to acquire at least 5 million events. At least 5 million events. So when you're acquiring 5 million events, okay, and you take your LOQ, which I'll be discussing, or myeloma events as minimum of 20 for calling it as definite cluster. Okay, so if you're taking 20 and you're acquiring 5 million events, okay, how much would be the sensitivity? So it will be like 2000 divided by 5 million. Okay, so how much is that? Anyone? So if it is 20 minimal events I need, and if I'm going to acquire 5 million events, okay, it will be around 0.0004. Okay, that is 4 into 10 to the power of minus 6. Okay, so that is the sensitivity which is needed. For example, if you're acquiring 1 million events, okay, you may not be able to attain that sensitivity, and that is called conventional flow MRD. If you carefully see here, if you're doing conventional flow, you may end up saying like there is no abnormal plasma cells. But for the same case, if you do a next generation flow, okay, you could still find the abnormal plasma cells of lower percentage still existing. Okay, so if you say with this conventional flow, if you call this as MRD negative, okay, and you sign it as negative, these patients still there are some neoplastic plasma cells which may cause relapse of the disease. Okay, so that is a use of doing next generation flow compared to the conventional flow. So next generation flow is nothing. You are doing a flow with increased sensitivity. That is, you are trying to attain a sensitivity of 10 to the power of minus 6. Okay, and for that, what you need to do, you need to acquire many number of events for minimum of 5 million events. So those who want to do MRD detection by flow cytometry, okay, you need to acquire a minimum of 5 million events, and then you can claim yourself that you are doing myeloma MRD by next generation flow. Okay, anything less than 5 million, for example 2 million or 3 million, you may not be able to touch that sensitivity of 10 to the power of minus 6. You may reach up to 10 to the power of minus 4 or 10 to the power of minus 5, not beyond that. Okay, so that is the use of next generation flow cytometry. Okay, now you can see this Kaplan-Meier graph. Okay, you can see that patients in CR and stringent CR, those who are next generation flow negative, they tend to have a relatively better survival compared to those patients who are NGF positive, okay, who tends to relapse or having a poor outcome compared to those who are NGF negative. Okay, so though they are in CR or stringent CR, this checking MRD by next generation flow cytometry will help you to predict the disease. Okay, so as I said during our as I showed you different responses. Somewhere we have been using this M protein, right? Especially in partial response, in very good partial response. Okay, we have been using this monoclonal proteins, but the problem is that serum-based markers, including monoclonal proteins, or on serum electrophoresis, were previously used as only method for response assessment. But as more patients were achieving deeper response, more sensitive methods were used for. So these were not much useful. Okay, and one more thing is that longer half-life of paraproteins. So myeloma cells which are secreting the M, mainly immunoglobulins, tends to stay for a longer time. So even the plasma cells are destroyed, even this immunoglobulins which were secreted by the neoplastic plasma cells still exist in circulation, and they can give you a false impact. Okay, and additionally monoclonal antibodies, such as now for treatment we are using monoclonal antibodies, and even they can be detected as in a low level in the M band. They can give an M band like picture. Okay, because you are using a monoclonal antibodies, right? Even when you're doing electrophoresis, this drug, what you are given, monoclonal antibodies, can form an M band artifactually, and you can mistake that for persistence of disease. Okay, so you can call it as false positive in serum electrophoresis and immunofixation. So that is also there. So these are some of the drawbacks of checking, doing immunological methods for detecting is there a residual disease or not. Okay. Now, the two sensitive methods for checking an ultra deep MRD is one is next generation flow cytometry, and second is next generation sequencing. Okay. So as I told you, with next generation sequencing, what is needed? You need the baseline signature. You need the baseline immunoglobulin rearrangement which was present in the plasma cells or the myeloma cells. Now, with that immunoglobulin rearrangement which was present, you will be tracking it whether any myeloma cells are still there in blood or in the marrow. Okay, so that is NGS, next generation sequencing, where you'll use the tracker, you'll use the immunoglobulin rearrangement which was specific to the myeloma cells. Okay, whereas in NGF, even though you don't have the baseline diagnosis, still you can do flow cytometry. Correct? It is not mandatory for flow cytometry that you need the initial baseline phenotype. If it is there, it is well and good, better. If it is not there, still you can do it for flow cytometry. That makes flow cytometry stand out compared to molecular techniques. And the second beauty of flow cytometry is that time. You can get the report on the same day. For us, NGS, you may take, say, for example, depends upon institute to institute, it may take up to a week in many institutes. Okay. And sensitivity, yeah, as I told you now, I just gave you a calculation now. So if you want to have a minimum of 20 events cluster to call it as disease, and if you are acquiring 5 million events, you can attain a sensitivity of around 2 to 4 into 10 to the power minus 6. Okay, and NGS also has a similar sensitivity, or in fact slightly deeper than this, 10 to the power minus 6. Okay, so the number of cells you need to acquire is around minimum of 5 million, but here it is beyond that. 20 million cells has to be acquired, but 5 million is fine. Okay, because we don't have, the problem is that, see, what do you think? Like, what is the problem in acquiring larger number of events? I mean, like, what do you feel when you acquire large number of events? As I say, 5 million, 10 million. What is the problem you'll encounter? What are the difficulties we'll encounter? Yes.
The amount of data we are generating. So to process those heavy files, we essentially need a good software.
Perfect. So that is the biggest problem. As rightly said, that is the biggest problem. See, when you're acquiring 5 million or 10 million events, the size of that file will be too big, too big. And to analyze that file, you need to have a computer with a highly sophisticated graphic card and so and so. Okay, you cannot do that analysis in a conventional computer. You need a computer which has been enabled for PlayStations and so and so. Okay, that graphic card, for example, I'll tell you what, the system to with that specific graphic card, I can share it in the group, the specifications. That is costing around 10 lakh rupees. Okay, if you want to do that 10 lakh event analysis without any hang or any without taking time, you need that specification of a computer technically, and it would costing around 10 lakh rupees, which should have that particular graphic card. Okay, analyzing an MRD is very simple, for especially in myeloma. Like, it's not such very difficult. You can definitely easily, because you're interested on population which is expressing CD38 bright, and still you have other markers to refine it, and then you're going to check in kappa lambda, right? So analyzing an MRD and picking up the abnormal population technically by gating and something is not difficult. Relatively, you can do it. Where the problem is in the hardware and the software, especially. For example, you need to have that computer which can handle such a big file size. Okay, so that is the difficulty. Analyzing, it's very simple. You are going to do the same analysis as you're doing for 1 million events. The same way you're going to do an analysis for 10 million events. Of course, you will have some non-specific noise and something which will be coming as a disturbance, but still you can do it. The problem is the computer or the graph. I mean, for analysis, that specification is needed. So that there is the problem. Okay. So need for fresh sample. Yes, you need a fresh sample for flow cytometry, whereas in NGS, you don't need that. Even you can take it from the smears which you have made. Okay, so that is not needed. So diagnostic sample is mandatory for NGS. For us in next generation flow cytometry, it is not that needed. Of course, both are quantitative, and so these are some of the things. Harmonization is better with flow compared to NGS. Okay, so flow is more, papers have come, you know the gating strategy. So harmonization is better here compared to NGF. Cost relatively low compared to NGS. This we already discussed in PMRD, but still in myeloma context, this is the advantages of NGF over NGS. Okay, when I say next generation flow, remember it is a high sensitivity flow cytometry assay where you need to acquire larger number of events than what you conventionally do for MRD. So any doubts till now? Any doubts? Is that clear now? Is that till now it's clear? Right. Now coming to conventional flow, MRD by next generation flow cytometry significantly increased sensitivity of the novel Euroflow based NGF. So NGF, when it came to next generation flow cytometry, there need to be some guidelines which has to be put up. So the Euroflow group came up putting up those guidelines. For example, how many events to acquire, what are the minimal number of markers that has to be used. See, high sensitivity next generation flow cytometry is not just related to sensitivity. It also relies upon the number of markers or the minimum number of markers you need to use. Okay, for example, if you are very stringent in your antibodies, for example, you are just using kappa lambda, CD38, 138, okay, and with that you want to do next generation flow cytometry and you are acquiring 10 million events. Okay, still it is not a high sensitivity next generation flow because you have compromised on the number of markers. So I have seen some people who discussed next generation flow cytometry for myeloma without kappa lambda markers, which is not possible, which is not great. Okay, so when I say NGF or high sensitivity flow cytometry, it means it has to satisfy the number of events that has to be acquired, also the minimum number of markers which has to be there in the panel. When everything is satisfied, then you can call it as next generation flow or high sensitivity flow. Okay, so the Euroflow made some recommendations that these all should be there to qualify for next generation flow. Okay, one is the number of events that has to be acquired, the minimal number of markers which has to be there in the panel. All these things were been established. Okay, so the novel NGF approach versus conventional MRD with around 1/4 of all, remember, 1/4 of all MRD negative samples by conventional flow became MRD positive by next generation flow. So most likely by acquiring more number of events, cases which were found to be negative by conventional flow turned out to be positive. Or to put it in the other way, when you call an MRD negative by acquiring 1 million events, still the same sample can become MRD positive, okay, when you acquire 5 million events. Okay, so when I say MRD positive or negative, what is the cutoff here? There is no cutoff. When you find disease confidently, it is MRD positive. It is not like your BMRD or TMRD where you have a cutoff. BMRD, TMRD, I said you a cutoff, right? For example, in BMRD, with respect to BFM protocol, we call MRD positive when the disease is greater than 0.01%. Correct? Similarly, for AML MRD, we call it positive when the disease is more than 0.1%. Okay, but in myeloma, no such criteria. What has been claimed is if you find disease, if you find myeloma events, it is MRD positive. Okay, no matter you acquire 1 million events or 5 million events, you acquire 5 million events or 10 million events, still you find some myeloma events coming up. Okay, and you're confident that those are all myeloma events, 100%, then it is MRD positive. Okay, so high sensitivity flow MRD assay is described with LOD, which is limit of detection, close to 10 to the power of -6. Okay, ability to identify down to 20 plasma cells among 10 to the power of 7, that is 10 million evaluated bone marrow cells. So this is called LOD. I'll tell you all these things, don't worry. And limit of quantification of around less than 5 into 10 to the power of -6. Okay, this slide I'll tell you what is LOD, LOQ, I'll tell you at the end of the lecture. So don't worry about that. Okay. So they are doing around 10 million event acquisition. 10 million events. Remember 10 million events. But 5 million events should be minimum acquired because 10 million is a huge data. With the current setting in most of our laboratories, we don't have that computer to handle such a big data. Okay, as you analyze with Kaluza, first 2 gates, for example, your viability gate and singlet gate and third CD38 gate or CD45, when you draw the third gate, it will get struck or it will automatically close. It will shut down. So that is the problem with the current systems what we have. So to do an NGF with 10 million events, you need that robust computer with that specifications. Okay, so panel, it's nothing different from your diagnostic panel. It is the same as your diagnostic panel. Okay, for example, we have the same panel, but what would I suggest is that, like, in case if a daratumumab is given or a targeted therapy is given, you can add a SLAM protein. You know what is SLAM protein? I've already discussed in myeloma diagnosis. You can add up a SLAM protein like 319 or 229 or something. And similarly, if they want to give a targeted therapy or a CAR T therapy with BCMA, okay, B cell maturation antigen, then you need to add that particular marker in your panel. Now, BCMA, otherwise called as B cell maturation antigen or called as by the CD marker 269, is something which will be targeted to kill the myeloma cells in the setting of CAR T therapy. Okay, where they use the T cells to kill the neoplastic cells. Okay, so your clinician may ask you, was it expressing BCMA? At that time, if you have this marker, you can tell him, yes, it was expressing BCMA or not. And similarly, as I said, when 38 will be knocked out with daratumumab, you need an alternate gating marker. So it is better you add some SLAM protein like 319 or 229. Okay. Apart from that, the other things are all defining myeloma. Like this, 19 will be positive in normal plasma cells, whereas negative in myeloma cells. 28 will be positive in myeloma cells, will be negative in normal plasma cells. Okay. 81 will be downregulated in myeloma cells, whereas expressed in normal plasma cells. 45 will be moderate in normal plasma cells, whereas it will be downregulated in myeloma cells. 117 will be positive in myeloma cells and it will not be expressed in normal plasma cells. The other beauty of 117 is that it can also comment on dilution, whether the marrow has got dilute. 200 will be very bright in plasma cells. And one beautiful marker is 56, which most of the time helps us. 56 will be positive in abnormal plasma cells, whereas negative in normal plasma cells. 138 will be helping us for gating marker, and kappa lambda will be helping us to check the restriction of light chain. And remember, mark my point, like kappa lambda can also be used as a gating marker, which I'll show you today. Okay. So these are different panels as described by the Euroflow. So if you are using an 8-color flow cytometer, you need to run two tubes with these combinations. So these are 5 different combinations or 5 different panels have been shown to you. So if you are running an 8-color flow cytometry, you need to use 2 tubes, and these are the composition of the tubes. But remember, if you want to acquire 5 million events and 10 million events, if you are using 2 tubes, then in every tube you need to take 10 million events. So you need large volume of sample. You need to use large lyse to lyse those samples and get the cells of this quantity. So it's always better you do an myeloma MRD when you're doing NGF, where you're acquiring 5 million or 10 million events, by using a single tube and a 10-color or a 13-color panel. That is better, because if you are doing 8-color and using 2 tubes, obviously the volume of cells will be divided between the 2 tubes, and that may result in not reaching that desired high event. For example, 10 million or 5 million may not be possible in some cases. But if you use single tube, 10-color or 13-color, now all the samples you can use for that one particular tube, and you can relatively achieve easily a 5 million or a 10 million events as you desire. Okay, so it's better you use a 10-color panel or a 13-color panel with single tube. And when you're using a 10-color panel, these are 3 different combinations. So you can use any one of them. Okay, so this has been it has been in the Euroflow paper. So these are the minimum markers you should use. Okay, these are the minimum markers, minimum sensitivity. Okay, so you should use definitely 19, 27, 38, 45, 56, 81, 117, 138, kappa lambda. So these are the minimal markers which has to be used, 10-color. Okay, and minimum sensitivity level recommended by International Myeloma Working Group is the detection of 1 neoplastic cell in 1 lakh cells, that is 10 to the power of -5. Okay, or 1 to 2 cells in 1 million cells, so 10 to the power of -6. So you should reach this sensitivity. Okay, so to reach this sensitivity, you should definitely acquire how many events? If you are acquiring 5 million events, then 10 cells is the cutoff to detect it. Okay, if you are using 10 million events, then 20 cells will become the cutoff to find. 20 events is enough to call a disease. Okay, so if you are acquiring only 5 million, hardly you need to call a population as disease with only 5 events or 10 events, which is very difficult. Okay, but if you acquire 10 million, then you will have 20 events. Okay, then it is relatively better to call with confidence that is all those 20 events are abnormal events. Okay, so the markers used in routine clinical diagnosis and in targeted therapy, this I told you. Okay, so these are the routine markers which are used, the same 10 markers. But if you are using a targeted therapy, you need to include BCMA, or if they have given daratumumab or something, then you need to use SLAM proteins, such as 319 or 229. Okay, and I just discussed this. Okay, markers and how they are in normal plasma cells and how they are useful in abnormal plasma cells. Okay, this I also discussed in diagnosis of myelomas. Hope nobody has a doubt. Okay, so as I said, when you're doing a next generation flow, you should also take an effort to check whether the marrow is diluted or not. Okay, no point of acquiring 10 million events and all those 10 million events are predominantly from peripheral blood. Correct? Still, it could be MRD negative and the patient may relapse in the future. So you should also take an effort to check whether the marrow which has been submitted to you is not hemodiluted. So they have taken some effort to even establish the normal range for certain marrow representative elements. For example, mast cells. So for mast cells, they have established a reference range. So when it is within this reference range, it means like the marrow is not diluted. When it is lower than 0.002, that means the sample has got diluted. Similarly for nucleated red cells. Okay. Similarly for normal plasma cells. For hematogones. Okay. Mature B cells. Okay. Myeloid precursors. Endothelial cells and mesenchymal cells. So these are normal bone marrow cells and they have established a percentage for this. And if it is within this percentage, it means like it is not diluted. So I don't know how practical this is possible. Okay. My point is whether you find a marrow representative elements, it's fine. But to quantify that marrow representative element and to check whether it is between that range, I don't think so how practically possible that is. Okay. But anyhow, I just want to tell you that it has been established and certain things, this is existing. Okay. Now, any doubts till now? This LOD, LOB, LOQ sensitivity, you leave it to me. I'll take care because I'll be taking it sometime later. So, but till now, any doubts? Clear? No doubts. So, shall we go ahead?
Yes, sir.
Perfect. Now, approach for MRD, myeloma MRD approach, as I said, detecting myeloma MRD is not that difficult. What is more difficult is analyzing the data. Are the hardware and software which is used to analyze such a big data is the problem. If you just acquire 1 million or 2 million events and you are analyzing by your conventional computer and software, you are not doing NGF, you are doing conventional MRD. But the utility of MRD in myeloma is established only in NGF, which is next generation flow cytometry or high sensitivity flow cytometry. So analysis wise, it's both same, conventional and NGF. But you need that system configuration to handle that data, right? So, but still, we'll just check how we approach for detecting MRD. Okay, so initial gate, as we discussed with this is no way different from IPT, the same approach. So initially you gate the plasma cells with respect to site scatter CD38. Okay, so you take a very liberal gate, include all the populations which are CD38 bright, as well as try to take some populations which are exhibiting CD38 moderate. So what are the populations which exhibit CD38 in a moderate fashion? Yes. Populations that show CD38 in a moderate fashion. That is just below the plasma cells. What are populations? Basophils. Perfect. That's the first thing. Basophils.
Hematogones.
Yeah, hematogones.
Monocytes.
Monocytes. Then
activated lymphocyte.
PDCs comes, plasmacytoid dendritic cells. Then
activated lymphocyte.
Activated lymphocyte. But see, the important population is basophil because basophils are next brightest for CD38 after plasma cells. They exhibit CD38 in such a fashion that they just lie below the plasma cells. Okay, and as you rightly said, somebody with normal myeloid blast is missed. Okay, so plasma cells, gate plasma cells include some amount of basophils, hematogones, okay, monocytes, okay, normal myeloid blast. Sorry?
Immature NK.
Yeah, immature NK. Perfect. Very good. Very good. Excellent. So even NK cells. Now, why immature NK? Even NK cells are 38 positive.
Yes, sir.
Yeah, you can include NK cells. So you include all this population, and then side scatter CD45, purify them. NK cells will be 45 bright. You can eliminate them, and slowly you can eliminate, and then you can go for 38, 138. Purify. Okay, so draw a liberal gate so that you include some amount of CD38 moderate population. Then purify the plasma cells. So with respect to side scatter CD45, you can remove all these mature NK cells. Okay, these can be eliminated. The NK cells can be eliminated. Then with 38, 138, all other populations can be ignored. For example, basophils, PDCs, monocytes, they can all be cleared up. And then after purifying the plasma cells, what you do, you gate the plasma cells to across all combination of markers to check for abnormal phenotype. For example, 45 versus 56, 19 versus 38, 38 versus 81, 200 versus 38, 117 versus 38. So across all combinations, and try to pick out plasma cells which are showing abnormal phenotype. Okay, once you do, gate the abnormal plasma cells and also gate the normal plasma cells. Okay, so gate plasma cells which no abnormal phenotype, those are normal plasma cells, and gate the plasma cells which are showing abnormal phenotype. Okay, once you get this, now you check separately both these populations in kappa lambda. So if it is normal plasma cells, it should show that beautiful distribution across kappa and lambda. Or when it is an abnormal phenotype or abnormal plasma cell, it will show clonality with particular to kappa lambda. Okay, then you wait and quantify the clonal population. So this is one way of approaching MRD in myeloma. Okay, I'll just show you this. And remember, plasma cells sometimes show intracellular immunoglobulins. Okay, so they may sometimes show high side scatter. So when you're drawing a side scatter CD38 gate, make sure you put your gate from high side scatter, including some bright and moderate CD38, and draw a gate in such a manner. Don't draw a gate like a rectangle gate or a oval gate, taking only low side scatter and CD38 bright and moderate population. Always draw a gate including a chance of high side scatter population. Okay. Now this is the strategy what I told you. So live gate, then singlet, then CD45. Okay. So just gate your lymphocytes, and in the lymph, you again gate the lymph in CD19 versus 45, gate the B cells. So the B cells can act as a control for kappa lambda. And then what you do, you draw a very broad gate. This is what I told you. For side scatter, draw a gate with high side scatter. Don't draw a gate like this. Open up a gate with high side scatter population. Okay, CD for 38 bright ends here, but still be liberal, include some amount of CD38 moderate population, and then close the gate. So draw a gate something like this, then purify this population with respect to side scatter CD45. So I'm eliminating some amount of activated T cells and NK cells, and I'm taking only the plasma cells along with myeloid blasts, basophils, PDCs. All these populations are included in this. Okay, then go for further purification. 138 versus 38. Now you can see that one population is 38 bright and even 138 positive, whereas the other population is all 138 negative. So draw a gate something like this to include only the plasma cells, ignoring all other populations like monocyte, not myeloid blast, basophils, PDCs, so and so, so and so. Okay, once you got the purified plasma cell population, now what you do, you gate it across all the combination of markers and check for any immunophenotypic aberrances. Now I can see that there is a yellow color population which is 19 positive and 45 in the moderate, which is in the so this could be likely normal plasma cells. Okay, it is not exhibiting 56. Okay, it is exhibiting 81 in the normal fashion. Okay, it is expressing 27. Okay, and in kappa lambda it splits into 2. Similarly, there is one more population which is 90 negative, but 45 is moderate. Same to as this population, 45 is moderate. Now this population is gated, again check for any immunophenotypic aberrancy. It's not showing any aberrancies. And in kappa lambda, it is showing beautiful separation. Now coming to the third population, now this population is 90 negative and 45 is also slightly dimmer compared to above two populations. Now gate this population and you check, it is not showing much of any other aberrancies. Even 56 is negative, 81 is not down regulated, only 45 is helping us. Even 27, it is like touch and go, whereas the normal plasma cell 27 is here. It is not negative, but slightly lower than the normal plasma cells. Then if you check it with kappa lambda, you can see that it is lambda restricted. Okay. Remember, when you want to call it as a disease, the kappa lambda ratio should be so skewed around 1:10. For example, here it is 4, 1, like it should be 90 versus 10. It should be more than 90 versus 10, something like that. Okay. The population, the light chain to which it is restricted should be showing 90%. And the light chain, the other light chain should be only less than 10%. Only then you can confidently call it as light chain restricted. Okay, now you see this population. This is completely lambda restricted. And when I quantify it, it is around 0.01%. Okay, so this is one way of doing it. Okay, the other approach which I want to tell you is, again, I normally do both the approaches. First, I do this conventional approach, and then I do this approach before calling anything as negative. So in this approach, the first starting is same. So you get the plasma cell with site scatter CD38, draw a liberal gate, then purify the plasma cells with site scatter CD45 and 38, 138. Now what I do, I don't check for immunophenotypic aberrancies. Rather, what I do, once my plasma cells are purified, I directly plot it across kappa lambda. Okay, kappa lambda. Now what I do, I take only the populations which are expressing kappa and lambda for further analysis. Okay, only the populations expressing kappa lambda for further analysis. Now this way, my population is much more purified. Only pitfall with this particular approach is when it is a case of non-productive myeloma. Okay, when it is a case of non-productive myeloma, which is very, 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 very rare. Okay, this approach may not work. For all other myeloma cases, this will quite well work. Okay, now after purifying the plasma cells, you take only the population expressing both kappa and lambda in the kappa lambda plot. Now then you check for the abnormal phenotype. Okay, then you get the abnormal plasma cells. This way, you may wonder what is such a great difference between these two approaches. See, if it's a diagnostic point of view, and when you're doing a conventional MRD, the earlier approach may be much easier. But when you're doing a high event acquisition, you may have lot of non-specific events which will be coming as you purify only with the markers. There will be still non-PCs which will be sitting in your gate. And when you're directly checking for abnormal phenotype, these non-PCs can give you a lot of disturbance and they may falsely appear like MRD. Okay, but when you purify with kappa lambda, it is much more cleaner, and then you can check for immunophenotypic aberrancy, which will be easy for you to pick up. This is one advantage. Second, this is also useful when anti-CD8 therapy is given, because when CD38 is given, 38 is knocked out. Now you cannot use 38 as a gating marker. Now you can use a SLAM protein or some 138 as a gating marker, gate liberally and put it across kappa lambda and take only populations expressing kappa and lambda for further analysis. So that is also one more useful thing with this type of approach. I'll show you an example here. This is a different case. So live gate, singlet, similarly, and then CD45 bright, I'm including with a very liberal gate with high side scatter gate, and then purifying, excluding the 45 bright population. And then with 38, 138, I'm gating the populations expressing 38 and 138. I'm ignoring the populations which are negative for 138 and CD38 is not bright. This could be likely some myeloid blast or whatever I said, basophils or PDCs or whatever. So once this is the thing, instead of putting this plot across the combination of markers for immunophenotypic aberrancies, Now what I do, I apply here and take the populations which are showing only kappa and lambda. Okay. Now you can see, like, though I purified with 38, 138, still you can find there is non-PC population in that gate. So once if I'm get that population across kappa lambda, I can see the plasma cells exhibiting a good positivity to kappa lambda. So I'll take only this population expressing kappa lambda for further analysis. Okay. So this population I'll check for combination of markers for immunophenotypic aberrancies, and I can find this red population is expressing 56 in a dim fashion and 38 is downregulated. Similarly, the red population is showing lack of 19. Okay, whereas the normal plasma cells which are in green are showing 19 positive. So I get that, and finally you get the abnormal population in kappa lambda to quantify it, and normal plasma cell population you can see it splits in kappa lambda beautifully. So this is another approach. Okay, what I want to say is that you can use kappa lambda as a gating marker. Okay, so in certain times it will be very useful for you. Okay, now anti-CD8 therapy given, daratumumab is given. You can use 138. You can use SLAM proteins. Okay, and you can also use kappa lambda. For example, suddenly a case has come to you where the clinician has written like, we are given anti-CD8 therapy, then you may not have SLAM protein. SLAM protein, if you have it in your panel or if you have the antibody readily available in the lab, it's fine. If it's not there, then you can use CD138 and kappa lambda to get the plasma cells. Once the plasma cells are sorted out, you can check the plasma cells across different combination of markers for immunophenotypic aberrancy. So that is one way of doing it. Okay. Any doubts?
Sir, can
Yeah.
we initially use CD138 in place of 38 in each and every case? Is there any problem in doing that?
Yeah, I told you now during diagnosis, the problem with 138 is that it tends to get downregulated with time. You do one thing, like when you get a myeloma sample, you acquire it fresh with the markers, and then you acquire it 1 day later and 2 days later, and see the expression of 138. 138, as far as literature is all concerned, 138 is very specific to plasma cells, but 138 tends to go down with time. That is the problem with 138.
Okay, sir.
Any other doubts? No doubts? So now what we do, we'll go into sensitivity, LOD, LOQ. So when I'm saying about NGF, next generation flow cytometry, when I say 10 to the power of -6, what this really means, let's check it out. Now, sensitivity in general terms, this slide I already discussed in PMRD, but still I'll just to use this as a starting point. So sensitivity of an assay, especially in biochemistry, they use this term to represent the smallest amount of substance in a sample that can be accurately measured. Okay, for example, if you are measuring glucose, okay, what is that minimal amount of glucose that can be measured in the plasma accurately with confidence? Is the sensitivity of the particular assay. If they're using a specific type of methodology, and when they say it's the sensitivity of this method is so and so, what it implies, what is the smallest amount of substance that can be accurately measured with that methodology. If method A is detecting glucose to a level of, say, right, for discussion, 20 milligram per dl, and method B detects glucose of 30 milligram per dl, then method A is more sensitive than method B. Okay, so this is about biochemistry. So sensitivity initially started with respect to biochemistry, since more it deals with analytical assays. So since flow also does with analytical assay and quantification assays, this slowly percolated into the flow. That is our problem. Okay, so in flow cytometry also you will be using sensitivity, especially not in diagnostic setting. In diagnosis, you have lot of blast or lot of abnormal cells. So you acquire 1 lakh events, you can get the disease population as a big chunk. So there is no problem during diagnosis. But in MRD, what happens is your disease cells or the abnormal cells are reduced so low that it may be around 1 in 1,000 or 1 in 10,000 or 1 in 1 lakh. In such a setting, what is that sensitivity of your assay to pick up that one cell in 10,000 or 1 lakh normal cells? There, the point of sensitivity comes in flow cytometry, especially in high event acquisition analysis like MRD or PNH. Okay. Now, sensitivity in flow language, especially in an MRD setting, means the smallest amount of leukemic cells or the abnormal cells among a background of normal regenerating cells in a sample that can be accurately detected. So this is very important, accurately detected and also quantified precisely. So you need both accuracy as well as precision. So you know what is accuracy and precision, right? Accuracy is shooting the bullseye perfectly at the center. Precision is the ability to do that repeatedly. So first time maybe all by chance or luck you can hit it off straight on the point, but the ability to hit it right there every time you shoot is called precision. Okay, so the ability of the assay to pick up a minimal amount of or a smallest amount of leukemic cells in that sample that can be detected accurately and precisely is sensitivity. Okay, now flow cytometry, you can reach a sensitivity of 10 to the power of -6. Especially in myeloma, this sensitivity is needed. For BMRD, TMRD, you may bit compromise on that. But 10 to the power of -6 means it is this one, 0.0001. Okay, you need to attain this sensitivity, especially for myeloma. Okay, so when you want to attain this sensitivity, what is needed? You need to acquire a larger number of events. You need to acquire a minimum of 5 million events. So when you acquire 5 million events, okay, to attain the sensitivity, you can detect at least 10 plasma myeloma cells. Okay, that is called LOD. I'll tell you what LOD means. Now, sensitivity increases with high event acquisition and the number of MRD markers are in the panel. So this one I just discussed. Okay, so it's not just events which are acquired. You also need to have good informative MRD markers in your panel. With these two, you can call it as a next generation flow cytometry or a high sensitivity flow cytometry. So how could you determine this? You can determine this by doing certain experiments called limit of blank, limit of detection, and lower limit of quantification experiments. Okay, now what is limit of blank? So before I go into limit of blank, for example, so how many events to acquire? So when I say you want to attain a sensitivity of 1 in, how much is this? 1 in 1 lakh. Okay, 1 in 1 lakh, which is 10 to the power of -5. Okay, that is 0.001. Okay, if you check, if I need to acquire to attain a sensitivity of, say, as I said, 10 to the power of -5, I need to acquire a minimum of 5 million events when I keep a threshold of 50 events as disease, which is LOD. That is, when I'm doing a myeloma analysis, when there is a kappa restricted abnormal myeloma population, which are 50 in number. Okay, my minimal criteria to call it as disease. For example, if I let me come like this to explain. So if I have only 10 events in the abnormal gate, myeloma gate, okay, these 10 events may be really myeloma events, or it could be some stray events or junk events which is coming to that gate. So you're not confident. Okay, but when you have 50 events, the chance of junk events or stray events to form 50 events in the disease gate, which when I say disease gate, that means like it is those events which are showing abnormal phenotype with respect to multiple myeloma markers and they are kappa or lambda restricted. Okay, when it is 50 events, okay, the confidence level increases because there is less chances for a stray events or a non-specific events 50 in number to form a disease population. Okay, so when I take that 50 as the number, I need to acquire 5 million events to attain a sensitivity of 10 to the power of minus 5. That is 1 in 1 lakh cells. Okay, if you feel 50 is also I'm not confident, I need a bigger cluster, then you need to take 100 events. Now, when you're taking minimum, I will give MRD positive when I find only 100 events satisfying the phenotype. When you take such a criteria, now what happens is that to attain the same sensitivity of 10 to the power of minus 5 or 1 in 1 lakh cells, you need to acquire 10 million events. You got it? You need to acquire 10 million events. Still, you are a beginner and you say like, no, even 100, I'm not confident. I need to go for, I need a good chunky cluster, something very similar to a diagnostic. Then if you keep that cutoff as 500 events, that those 500 events should show the abnormal myeloma associated phenotype and should be kappa or lambda restricted. Those 500 events, if you take, you will be very confident because chunk or non-specific events will not be 500, right? You can have only 10 events, 20 events as chunk or non-specific events coming into the disease gate. Okay, now if you have 500 events, to attain the same sensitivity of 10 to the power of minus 5, you need to acquire, see how many events? 50 million events, which is practically impossible. Okay, so this 10, 50, 100 is something called limit of detection or limit of quantification, which I'll tell you now. But still, just remember this. But one thing, if you observe, as the number of events which you need to call it as disease, or the criteria which you set up to call it as disease, as it increases, the CV decreases. That means it is more reproducible. It is more precise. That if you run this assay, if you kept it as 10 events, when you acquire that particular tube, that 10 events are there. If you reacquire that same tube, there is a chance like you will not get the same 10 events. You may get this time 8 events or 12, 13 events. So it is not precise or it is not that reproducible. So the CV will be very high. Okay, whereas if you keep 1000 events and when you reacquire it multiple times, okay, there your CV will be very low because 1000 is a big number. So when you acquire on the second time, it may be 998 or 997 or 990 even, or it can be 1010, 1020. CV is not going to be affected much. So it is more reproducible and precise. So this is the way, but now I'll tell you what is LOB, LOD, and LOQ, and then I'll come back to this. Now, how is sensitivity defined in rare event analysis is, first, in simple terms, is defined as the ability. So this one I just told you. You need to establish something called limit of blank, which will tell you about the background. Then you need to establish something called limit of detection, which will tell you about the analytical sensitivity. And then analytical sensitivity is the lower number of events which can be accurately measured. Then finally, functional sensitivity, which will be established by lower limit of quantification, which will tell you about the accuracy as well as the precision. That is, multiple times if you're able to do also, you should be able to pick up those events. That is LLOQ. Now, what is limit of blank? So in a BM, so normally this LOB, LOD, LLOQ, normally they do it for a BALL sample. Okay, so I'll just tell you in context of a BALL sample. So how do you do LOB is that limit of blank is something where you take 5 non-BALL samples. Now I'm doing LOB for BMRD. Okay, I'm doing LOB, LOD, LLOQ for B cell MRD analysis. Okay, remember, now I'll take 5 cases of non-BALL. It could be a staging marrow, or it could be an ITP marrow, or it could be an AML MRD marrow, whatever. Non-BALL MRD samples, minimum 5, or you can use also 10 samples. And you use the samples and stain in a similar way as your BMRD. For example, CD19, CD10, CD34, 38, okay, 45, 73, and so on. So you stain them as you do it for or process them as you process for PMRD. Now you acquire that in the flow cytometer. So now what you do after acquiring, you would have already drawn templates, right? I showed you what is template. Okay, for example, based on the LIP, you would have drawn template. So now you check how many of those events are falling in that MRD gate. When I say MRD gate, that is MRD events. So it should be 19 positive, 10 bright, 34 positive, 38 downregulated, 73 overexpressed. So you check how many events are falling in that MRD gate, satisfying all these LAIPs. Ideally speaking, theoretically speaking, how many events should be falling in that gate? Anyone?
So no one.
Sorry?
0.
0. Perfect. Theoretically, 0. Correct? But practically, that is not possible. You may have certain events, non-specific events, which will fall. Okay? That meaning that events which are falling in that particular MRD gate is called limit of blank. That is when you're testing. Let me tell you in biochemistry. When I'm checking for glucose, same example. When I'm checking for glucose in a sample which has no glucose, and when I run it, some value will be given, right? The machine will not say 0. It will give some like 5 milligram per DL. That is called limit of blank. Similarly, in flow, when I draw a template for BMRD and finally put a gate like BMRD gate, which has events which is satisfying all my LAAPs, and when I run a non-BALL samples, 5 non-BALL samples, and check how many events are falling in that MRD gate, theoretically it should be 0. But practically, there may be some events falling into that. It may be 2 events, it may be 3 events, it may be 5 events, or it may be 10 events when your processing is so bad, or it may be more than that. It depends.
Sir,
So
if we
that-
are taking multiple LAIPs, then we'll take the highest one.
Sorry, come again. When you have multiple,
We are checking multiple plots for different LAIPs, right?
yeah, that is what. So now this is a
Highest.
controversial. That is a problem with establishing LOB, LOD, LLOQ. Because see, every disease has a different LAIP. But when you're doing, you use a classical one. For example, 19 positive, 10 positive, 34 positive, okay, 73 overexpressed, 45 negative. You take such a case. I got your point. You say like for every BLL, the LAIP differs. So which should I use?
No, that is okay. We'll take into account all the possible ones. Like when you taught us, you showed us the possible LAIP in
Yes. Yeah.
BMRD. But if the limit of blank is different across various markers, then the highest one to be taken?
True,
Like
correct.
I
Yeah, obviously, yes. Whichever highest. Yes, correct. Very, very true. So, for example, for one sample with the template, what you have drawn, when non-BMRD samples, when you run, it is falling, 2 events are falling in the MRD gate. And with another template, what you have drawn, and you are running the same non-BLL sample in that particular protocol, and 5 events are falling in that MRD gate, then you need to take 5 as your limit of blank. You always need to take the higher number.
Okay.
Right? So, is that clear for everyone? See, this is tough. But since it was just requested, I'm telling. Is anyone not understood? If anyone has
Sir?
not understood, yeah.
If there is limit of blank, let us say there are 5 events are coming in our essay. So should we increase our limit of detection according to that?
Sorry, come again. Please ask your question again.
Like if our limit of blank is coming 5 events and 1 million, and should we increase our limit of detection according to that?
No. You don't go for limit of detection now. What I'm speaking is limit of blank. You understood what is limit of blank?
Yes, sir. But if those limit of blank that is falling in that gate where we are detecting our events, that may be interfering with that event. So are we going to increase according to that blank? Or
I'll tell you, don't worry. Now, LOB is something like very simple. You have drawn an MRD gate and you're acquiring non-BMRD samples, and the number of events falling in that MRD gate is called limit of blank. You clear with that? Now I'll tell you what is limit of detection. Okay. So once you have established limit of blank, limit of detection is more a mathematical calculation. Okay. So once, see, I'll just read out. For LOB detection, 5 non-BLL samples are processed for BMRD analysis, and approximately the number of events which you want to acquire depends upon what you are practicing. For example, if you want to do high sensitivity, you can go up to 5 million events. For BMRD, 2 million is fine to achieve that cutoff of 0.01. Okay, so it depends. So this is, I've taken it from the paper, but still it depends upon the number of events what you are acquiring for your BMRD, the same number of events. If you're acquiring 2 million events, so you acquire the 2 million cells, and usually LOB is calculated as limit of blank. So I told you what is mean of blank. So when you are acquiring for 5 samples, so these are 5 non-BMRD samples, and I've acquired, so I have a policy of acquiring 4 million events for my BMRD. Now every time I acquire more than 4 million, okay, or in and around 4 million. And these are the number of events which are falling in that MRD gate. Okay, actually these are all spurious events, but still they are falling in my MRD gate. Theoretically, it should be 0, but practically these are the events which are falling in my MRD gate. Now what I need to do, I need to take an average of these 5 tubes. Okay, so I have run 5 samples, 5 non-BMRD samples, BLL samples. And I found that in first sample, I got 5 events in that MRD gate. Second, I had 4. Third, I had 4. Similarly, fourth, 5 events. And in fifth sample, I got 3 events in that MRD gate. Now I need to take the average of this. Okay, and ST, standard deviation. Once I have got this, your LOB is calculated by mean of blank plus 1.645 into standard deviation of blank values. So that is, in this case, 4.2 plus 1.645 into 0.8366. Okay, so once you do this, you get the value of LOB. For in this example, it is around 6.7. So you can take 7 events as your LOB.
So, but in this, it is showing 3 into 0.8366.
Sorry, 3 times. Sorry, so this here, okay. Now standard deviation, see, this is something like theoretical again. Okay, but the thing is that 3 is, see, they are given like using criteria to display selection of subheading 3 times the standard deviation. Sometimes it's better you use 3 times. Like you can also use standard deviation, but the number of here instead of 1.645, they are using 2 times of 1.645. Okay, but the average is that you can use 3. Okay, or you can use, even if you want to strictly add that to it, this is the formula 1.645. Okay, but here they have used 3. Might be like 2 times of 1.645. Okay, I don't know like what is the reason for 3. Conservatively, they are using 3 times the standard deviation of value. Okay, but the criteria
it may be above the 3 ST that is outside the repeatability.
No, not that. I'll just get back to that. Like there is something, but it's nothing like a specific reason. More is always better when you are, see, as we discussed, when you have I, you always need to take an higher number compared to. So if even they can use 2 also, but the one which is given in the formula is 1.645. So it is 1.645 into 0.8366, but still here they have used 3 for some reason. You can use 3 or you can also use standard deviation, right? But since they are using a higher number, it's fine. They are being more conservative. They are being more cautious that their LOB should not be low, because your LOD calculation depends on LOB values. Now LOD is calculated similarly like LOB plus 3 times ST. So you can at least use 1.645 or 3 times ST, anything. Higher is better. So here also the formula is the same for LOD calculation also. The formula is, it is for LOD, the formula, actual formula, theoretical formula is LOB plus 1.645 into standard deviation of blank. But here again they have used 3. So that is being more conservative. Okay, so they have used 1.6.7 plus 3 into 0.8366. So their LOD is 9.2, which rounded off to 10 events. Now, once you do, you cannot take this 10 events as the LOD. You need to validate that you can able to detect these LOD events and differentiate it from non-BALL events. Okay, so this 10 events you need to validate. How do you validate this? Okay, I'll show you. Now, this validation of 10 events will be done by dilution and spiking experiment, which I'll tell you in the next slide. Finally, this LOD will tell you about the accuracy of picking up the disease events against a background of normal events. Okay, so what that means is when I have 10 events as a cluster, when it is showing those LAIPs, I can confidently call them as leukemic events. Okay, but what is LLOQ is that when I'm acquiring the same tube multiple times, how confidently will I be getting the same 10 events is a question. So keeping 10 events, so next time if I acquire, this 10 events may come or may not come. Maybe it may reduce to 7 or it may increase to 13 or it may increase to 15. Okay, then comes LLOQ. So LLOQ is something like multiple times you acquire, you get those events, and the difference between these events will be less than 20% or not more than that. So it is more dealing with precision. Okay, for example, if these 10 events, if I keep my LLOQ same as LOD, and I take this 10 events as my LLOQ. Now the problem with keeping 10 events is that when I run it multiple times, and when I calculate the CV, the CV will be more than 20%, which is not acceptable. Okay, so for precision, now LLOQ will be definitely more than 10 events. Now, how to establish that, I'll show you. Okay, till now this is LOB, and you know how to calculate LOB and how to theoretically calculate LOD. Now, LOD has to be validated. Okay, that will be done by dilution and spiking experiment. What is dilution and spiking experiment is that you take a leukemic sample where there is leukemic cells, you check the count of that sample, and you also check the count of a normal control marrow, for example, an ITP marrow or whatever marrows, or a staging marrow or something. You check the count of it. You drop the particular blast into that particular control sample so that the blast percentage is around starting with 1%. Okay, 1%. Then with that, once you attain that 1%, what you do, you serially dilute that by serial dilution, so that the 1% in the second tube it becomes 0.1%, and 0.1% becomes 0.01%, and then the next tube it becomes 0.001%. So similarly, you dilute the samples, okay, and then run it in the flow cytometer. So once you run it, you get something like this. In dilution 1, your MRD will be around 0.4%. Okay, in dilution 2, it will be 0.04%. Okay, now this is about the percentage. You also need to check out the number of events. Okay, now you need to check, could you able to detect that LOD event what you derived can be able to, the LOD event what you derived theoretically is able to detectable in your assay. For example, now theoretically we have detected like 10 is our LOD events. Okay, now here they can able to show that they can able to figure out that 10 events they can go up to 11 events, touching a sensitivity of 0.0001%. Okay, similarly they can, it is not enough you show it one sample, you need to show it with 5 different samples. Remember, this is so tough, so you need to do it with 5 dilution and spiking experiment for 5 different samples, and you should show that you can able to go and touch that LOD. And this is the way you validate that LOD. Because theoretically you can derive LOD, but you should show that it is practically possible to go and detect that leukemic events of that LOD. In this case, 10. You see that in sample 1, they can able to touch that. In sample 2, they can able to touch. Similarly, in sample 3, they are almost there, 9. In sample 4, they are touching it. In sample 5, they are also touching it. So when you're able to touch it consistently with 5 samples, then you can take that your LOD is 10 and you have validated it. For example, they are not able to touch this 10 events. For example, they have 17, and in the next they are not able to touch 11. Say, for example, it is going 0, or it is becoming 1, or it becoming 2. Then they cannot take their LOD as 10. They need to fix with whatever they got here. The highest number of events, which is stable. And you should also see that it reduces as your dilution. Say, for example, they have gone in 1 in 10 dilution, means it should reduce in the same manner. So, for example, here, what should I say? 20,000. It's 20,000. Here it should become 2,000. Then it becomes 200. Then becomes 20. Then it becomes 2. Something like that. Progressively, it should decrease as per your dilution. What you have done. So that is how you validate your LOD. Okay. Now, once you have done your LOD, okay, you need to do LLOQ for in and around your LOD. So you definitely know your LLOQ will be more than LOD, right? So in this case, 10 has been described as the LOD. Now LLOQ you should frame for 10, something more than that, 20, and something even more than that, 40. So you need to do LLOQ for CV check, precision check. So with 40 events, if you see, they can able to attain a CV of 5%. Okay, you can see here. But when they take 20 events as an LLOQ, when they are checking for MRD events, it is not that reproducible as when it fixed for 40 events. For 20 events, the CV increases to 28%. And when it goes for 10 events, it even more worse, 39 CV. But we need a CV percentage of less than 20. So here, this is 28%, which is more than 20. So the best is to take 40 events as their LLOQ, which means only when they get 40 events in their MRD gate, finally, after all this sequential gating, after satisfying all the LAPs, once they get only 40 events, they can confidently call that as leukemic events. Anything less than that, it is not satisfying LLOQ, but it will satisfy LOD. Okay, so for your, since MRD is a quantification assay, by number you are giving a quantity, right? So you need to stick on to LLOQ and not LOD. So anything less than 40 events, you are not confident. So you need to keep your LLOQ as 40 events. Okay, and this, how this 20, 40, and 10 events are done is, you need to calculate the absolute count of blast and the absolute count of the control marrow, and you need to drop that volume of leukemic sample so that the events are exactly 40. It's not like serial dilution as you did for validation of LOD.
Sir,
Okay.
isn't it that way that you're having this dilution where you are getting 40 blast events, no? I thought they can choose that dilution then and then do it recurrently to get the CV.
Like serial.
Yeah, because when they are doing dilution, it is not following the dilution rule, of course, because as you said, 20,000, then it became 1570.
Yes, true. See, it is not, yeah, here it is like for validating your LLOQ. For validating LOD, you can do serial dilutions. Okay, for validating your LLOQ, you need to drop, your calculation has to be so precise that you drop that events into that control or a background sample.
But
Calculate
that
and
is so challenging, na, sir, to get
then,
the
yeah,
exact
very
dilution.
challenging. See, I'll tell you what, many people are doing MRD. But if you ask me how many people have done this LLOD, LLOQ, and all these experiments, it may be some in India. I don't know how many people would have done. Maximum 10, 20, 10 people, 10 labs. Because now what they do is that based on published papers or something, they take that 50 events. When you are using 50 events as your LLOQ, you need not do this.
Yeah, sure.
Because it's already published in papers. When you want to go much deeper and want to prove that my LLOQ can be less than 50, then you need to do all these funda experiments. If you want to take 50 as your minimum LLOQ, then they may not ask you this, because 50 is a good number, confident number, which you can happily have and do the MRD without doing all these exercises. But if you want to say for a,
correct,
yeah.
Mostly labs are doing LOD, just diluting and spiking.
Yes.
And then, yeah, as you are correctly saying, 50 events if we are taking, then LLOQ.
Then you need not do this. But if you want to challenge, this is done from one of the India's premier lab. like this is from TMH. No, I have taken it from their paper. This is so tough. So
Right.
normally what we do dilution. We'll check whether we are touching the LOD, and anything beyond your LOD or 2 times LOD and 50 events is fine. But when you want to go, say like my LLOQ is 20 events, then you need to do this. You need to prove that 20 events is reproducible across different samples. And for that to do, you need to add that exact number of blast into the control sample, which is, you know how they do it. See, I can say, but for some people, it will be like it will be so confusing. You need to stain the sample. Okay, the blast, you check the blast percentage, and you know the total count of the sample, calculate the absolute count of blast. Similarly, in the sample, control sample, you know the total count, okay, and then you calculate in such a way that how many leukemic cells, I mean, how much volume of sample, leukemic sample should be dropped into the control sample to have 40 leukemic cells. And that's how you need to calculate. And then, and similarly for 20, you need to calculate. And similarly for 10, you need to calculate and then acquire. So this is quite tedious. So you can also stain it and then check for counts. You stain it with fluorochromes, and then because there is cell loss every time when you wash it, right? So initial checking may be wrong. So once you stain it and before acquiring, you can check the counts, total counts in the cell counter, and you can also check the leukemic cells in flow cytometer, and then you can spike it. That also can be done, which will be more representative than spiking it before washing and staining. Don't worry, people who don't understand, just ignore it. It's very tough. So this is, since it was requested, I just told you. At least theoretically, you should know what is LOB, LOD, and LLOQ. So don't do me like it's a bit complicated. That's why I didn't touch. But since it was asked, I took it.
Sir, for LOD, we should start with 1% dilution or any.
Sorry. Come again. For LOD.
For LOD, we should start with any spiking or how much we should.
You can, if you want, you can start with 10%. Or see, for example, you have got a leukemia, acute leukemia case where the blast is 30%. Now, from 30%, you start with 1 in 10. That becomes 3%. Then you one in another serial dilution, 3 becomes 0.3, then 0.03, 0.003. So you can start with something like that. Start with 1%. Because 1% less than.
How long we have to go?
How long?
Means how long we have to do the dilution method? How many steps?
No, that depends. Like, see, if you want to have a sensitivity of 10 to the power of -5 or -6, so you start with 3%. Like, just calculate now. 3 is the first tube. Then second tube will be 0.3. Third will be 0.03. Okay, fourth will be 0.003. And fifth will be 0.0003. Finish 5 tubes. There is no point need to go further dilution. It depends upon what sensitivity you want to touch, 10 power -5 or 10 power -6.
Okay.
Yeah. So, do we have time? It's time. So we'll close for this today because this LOD, LOB would have almost confused everyone. I know. So what we'll do tomorrow, we'll just check with MDS and cover up some myeloma MRD also along with that. So that was the plan, because now myeloma MRD live analysis cannot be taken. Like it will be a bit the sensitivity LOB, LOD has confused everyone, I suppose. Still, any other doubts with respect to anything regarding today's class or with respect to anything? Okay, right. So no problem. Yeah, please.
So for all MRDs, we have to do bulk lysis, right, to get these events. So,
yes.
So for plasma cell MRD, you do bulk lysis, then do 2 washes because we have to do kappa lambda and then do staining, like we do diagnostic plasma cells.
Yes, exactly. Yes. True. Yeah, bulk lysis for any MRD, bulk lysis. The beauty of bulk lysis is that it gives you a good cell pellet. Second is that it will take off all your platelets and other things now, which are there in the plasma other immunoglobulins, everything, these all will be removed.
And
So
sir,
you'll have, yeah.
Sorry. Yeah, sir, please go ahead.
No, that is the reason. Like you are also removing all the interfering substances away. So what you get is good cells you can stain and then you can acquire. That's
And for this, you have to essentially use Versalize or you can use Optilize.
See, this is basic. When you want to do lyse, stain, and wash, always you should use a lyse without fixative. I'm not saying Versalize. Versalize is a special type of non-fixative lyse which uses saponine for lysing, I suppose. The best is ammonium chloride.
We have
Best is
that, yeah.
You can try, because you can, if you are a Beckman customer, you can use IoT lyse, which is an ammonium chloride. Versa is it's a non-fixative lyse, but the way of the method of lysing is by saponin reagent. I don't know, but it's something different. Optilize is something which has fixative. So whenever you are doing a stain, bulk lyse, stain and wash, or to make it simple, when you are lysing the sample before staining it, never use a fixative lyse with fixative. Always use a lyse without fixative. If you are doing stain lyse wash, it's up to you. You can use anything, lyse with fixative or lyse without fixative. For MRD, it's always like lyse without fixative, since we do bulk lyse, stain wash.
Okay, sir. Thank you, sir.
Yeah, thank you. Thanks a lot. So tomorrow we'll finish some live analysis of myeloma, MRD, and some MDS cases, and we can also go through some MDS to finish off.
Thank you, sir.
Thanks a lot. Take care.